Hi, everybody, and welcome. My name is Hope. I'm the Climate Communications Officer at Healthcare Without Harm Europe. I want to thank you for joining us today for the webinar, Decarbonizing Clinical Settings, Low Carbon Surgery. So we are here today because surgery is a critical frontier for sustainable healthcare. While it is a vital lifeline, it is also very resource intensive. In 2019, surgical care accounted for roughly 1.25% of the UK's total greenhouse gas emissions. With individual surgical footprints ranging from 5 kilograms to over 400 kilograms of CO2e equivalent, and to over 1,000 kilograms for an entire surgical patient pathway, the need for a low-carbon transition is clear. Yet, as climate change accelerates, bringing more frequent climate extremes, the need for surgery will grow. This, combined with aging populations, with staff burnout, and insufficient staff training, could create a perfect storm for healthcare. Consequently, healthcare systems face a dual imperative. They must adapt to protect healthcare professionals and patients' access to care while simultaneously reducing their emissions. This is our challenge, but more importantly, it is our opportunity. And today we're joined by a pioneering panel of speakers who will shine a light on the transformative interventions before, during, and after surgery to reduce emissions and improve health outcomes. So before I introduce our first speakers, I'd like to briefly highlight some of the platform's features and the agenda of the day. Firstly, please note that this webinar is being recorded and will later be made available on our YouTube channel. On the right side of your screen is the live chat tab, which is where you can share your thoughts, your comments, and any questions with the attendees and the speakers. The same chat is indeed where you can post questions to our speakers. Please do specify to whom your question is directed. That will help me as a moderator to suss them out and make sure they're directed to the right speaker. We will aim to address those questions during the panel discussion before or after, and we encourage our speakers to respond in the chat if they're able to. For today's webinar, we are joined by 5 speakers from across Europe who will share their insights and knowledge on decarbonizing surgical care. Each speaker will share their work individually, 5 in a row, and then we will follow it with a panel discussion. And I want to share as well that after this session, later this year in the fall of 2026, we will publish a resource that summarizes the key insights and recommendations from the speakers shared today. This is the 3rd resource in a series that we've done over the past 3 years focused on providing healthcare professionals with solutions they can implement in their clinical practice. The first, the Pocket Guide for Healthcare Professionals to kickstart your decarbonization journey, was published in 2024. And most recently, we published the Healthcare Leaders Handbook for Setting Decarbonization Targets, published this June. You can find links to both in the chat right now or shortly after. Finally, before we get into our speakers, we'd like to gauge your knowledge and your needs on this topic. On the right-hand side of the screen, on the polls tab, you will find 3 questions now. We want to know first how familiar you are with approaches to reducing the carbon footprint of surgical care. Second, if your team or organization has already implemented any actions to reduce emissions from surgical care. And third, what is the biggest challenge to implementing low carbon surgery in your setting, if you feel eligible to answer that. These polls will remain open for the next few minutes, again on the polls tab on the right side of your screen, which is just underneath the chat button. Please take a moment to answer them. It will really, really help us. And also, if you have any experiences that you want to share in the chat, introduce yourself and say where you're joining from. We would welcome that too, so we can get a sense of who's in the crowd with us today. And thank you for taking the time out of your busy work schedule to join us. It means a lot to us, and as well as to the speakers that have joined us from all over Europe today. Now, without further ado, I'd like to introduce our first speaker, Joseph John, who is a urology specialty registrar at the University of Exeter and Royal Devon University Healthcare NHS Foundation Trust, a PhD candidate at the University of Exeter, and the lead for sustainable care pathway development with Getting It Right First Time. Welcome, Joe. Hey, Joe. How are you?
Thank you very much for the invitation to speak today. So it's great. Can you hear me?
We sure can. We can also see your slides, so I'm going to hand it over to you now. Thank you.
Okay, thank you. Thanks very much. So so thanks for the introduction. I'll go straight on to the next slide to explain a little bit about what Getting It Right First Time is. So Getting It Right First Time, or GIRFT, it's a national quality improvement programme within the NHS, primarily in England, but we do have some specialty footprint in the other devolved nations in the UK as well. And what this national programme is focused on is really improving the quality of care by finding unwarranted variation in care. So sometimes care can vary between locations for the right reasons, but often it's actually not necessary. So we're picking out that unwarranted variation and trying to improve on that by benchmarking, by understanding what good looks like across the country. Some key tenets of the GIRF programme are that we have work streams in every medical and surgical specialty, which are led by very experienced clinicians, consultants in that area. They visit every hospital in the country, and we use a lot of data to really help monitor progress and identify good practice. We've got a strong focus on implementation and on pathway redesign. So what does this have to do with sustainability? Well, in the UK, we've got the Greener NHS. So this is the part of the NHS tasked with delivering on our net zero commitments by 2045. And you can see on the left there all of the different areas that the Greener NHS are addressing. One of which, but a really big and important one, is sustainable models of care. So this is about redesigning the care that we deliver in order to make sure that we're using resources as effectively as possible, that we're using our purchasing power and the decisions that we can make as healthcare professionals to enhance our net zero priorities. And you can see that graph on the right there, looking at the NHS's change in its carbon footprint over time. There are some areas where we've made fantastic progress, such as building energy use and anaesthetic gases and metered dose inhalers, but there's lots yet to do. And if we look at sustainable care delivery and sustainable models of care, we can affect demand right across all of these different themes to bring down the NHS's carbon footprint. And the Greener NHS doesn't have this sort of clinically facing presence. So what's happened in recent years is we've been working together, so GIRF and the Greener NHS, to really address sustainable care model. When we started looking at this, we felt like we needed a structure, an approach. So we actually developed this new methodology called the ELA methodology, which is Environmental Lessons Learned and Applied. And we basically have a process that we follow here where we choose a care pathway. That might be bladder cancer care, which is the first one that we looked at, or hip replacement and the pathway for that. And we choose a pathway that's likely to have high carbon emissions, and then we map out what happens to patients through that pathway at a national level, how many of each type of intervention, test and treatment are they getting, and then what does the evidence say about how we could make those pathways more environmentally sustainable, specifically looking at carbon at the moment. We also look at what's happening that is sort of, a good low carbon practice already across the UK, and we bring all of that together and do modelling for that pathway to understand what the opportunities are to decarbonise it. We do Pareto analysis, as you can see from this graph on the left here, to identify what are the biggest priority interventions that we should really focus our efforts on to make sure that we're really having the maximum possible impact. And then we bring together patients and clinical experts to work through those recommendations and say, all right, so this is the idea. This is, it could be day case surgery. It could be a type of one-stop assessment. But how do we actually make this practical and implementable in real-world practice? So it's really trying to offer something to clinical teams across the country that they can actually use and work with that doesn't require them to be carbon literate necessarily, but just requires following clinical instructions for implementation. So we've now got a work stream looking at this within GIRF. We've produced 3 national guides so far for these 3 different pathways. So that's stones, bladder cancer care, and the hip replacement pathway. But we've got many more coming out in the near future, including in dermatology and psychosis and more surgical pathways. We're very fortunate to have research funding from UK Research and Innovation and the NIHR to both support the scale up of this, so we can understand how do we really scale this up across our health system, but also to support the evaluation to make sure that we can implement these recommendations and to make sure that they're not having unintended effects and to make sure we can maximize the co-benefits on offer here. And a really key part of this is about building our team, and some of the team members are shown on the right here, but this really is a large collaborative effort. So to focus in a little bit now, so the first pathway we looked at was bladder cancer care, and we've got an infographic here showing the 12 recommendations that we arrived at as being the biggest opportunities for decarbonising this pathway. I won't go into them in detail because I haven't got time, but the sorts of themes that we address are on the left here. So it's optimising decisions, it's one-stop and same-day assessments, whereas previously patients were being seen, over time and different locations, and it was a really inefficient pathway. Waste reduction, risk stratification, so using clinical evidence to say how can we make sure that we're using our resources for the high-risk patients, and when patients are low risk, we're maybe de-escalating investigations and treatments. Avoiding theatres, the really carbon-intensive environment that you all know about, doing more day case surgery to avoid admission, and then looking at anaesthetics and how we can choose the greenest option there. We've done some evaluation alongside this, looking at co-benefits for patients in terms of their experience and their outcomes. We've looked at cost as well. So we think this, if this pathway were optimally implemented across the UK, it would save patients about £800,000 across the board, and the NHS over £32 million. So there are key additional incentives here that we really need to lean into. And we think that going from current to optimal practice in England, we could save about 2,500 tonnes of carbon dioxide equivalent. So what does one recommendation look like within this? So this is our case study area. We've chosen laser ablation of tumours to talk about here. So what this involves is, historically, we used to operate on all bladder tumours, bladder cancers, in operating theatres. So that patients have a general anaesthetic. They'd go into the really carbon-intensive environment with, a lot of energy used for heating, ventilation, and air conditioning, more staff members present, fewer patients treated per unit time. But what we know actually is that for small recurrent tumours, which are quite common in bladder cancer, we can actually treat those when we see them at the time of a checkup in clinic with a simple local anaesthetic, camera test or cystoscopy. So what this involves basically is having a £10,000 unit available in your hospital, available in the room when you identify those recurrent tumours. And this is a quality improvement intervention that we've addressed in this guide, and then has also been part of a wider initiative from the GIRF urology team as well. We audited this and we found that actually only 24% of units have this piece of equipment available, so that if you find that tumour on the day, you can treat it there and then. And for those units that don't have it, this means that patients either need to come back and have the same procedure on a different day, but with the ablation available, or they need to come back if the equipment isn't available at all, then, as it was in 26% of units, then they have to come back to operating theatres and have that general anaesthetic and undergo, an additional, more intensive, invasive procedure that they didn't really need. So there's a clear opportunity here to improve care and improve our resource use and decarbonise care as we go. And we think this would save about 100 tonnes of carbon dioxide equivalent. When I was looking for some pictures of this being delivered, you can see these are all from different local news reports across England, where teams have adopted this practice and have been so excited about it that they got in touch with their local newspaper and wanted to share this good news because of the fact that this is better for patients and better for the health service. So I thought that was a really interesting insight, actually, into how enthusiastic people have been about this particular intervention. It's probably worth thinking about why that is. And I think it's really because it's not just about sustainability. Really, this is about cost as well, patient experience, non-inferior clinical outcomes, and really releasing that important operating theatre capacity for other cases. So I think that's a really important take home when thinking about how to some of these green recommendations. And then what have we done in our greener guide? Well, these are some of the things that we pointed towards to really support people to plan for implementation of this recommendation. So it's about availability of equipment, having appropriate selection criteria, making sure that staff are trained appropriately in the technique, having the equipment there and then and ready to deploy with people who know how to deploy it, laser proofing your clinic rooms, putting together business cases, having appropriate policies, and then really allowing people time in their week to be able to deliver this, making sure that your lists are planned appropriately, and so forth. So when we look actually at, these are the recommendations we came up with as an expert group. And when we compare this to a behaviour change theory, such as the COM-B model, we can actually see we're addressing pretty much all the domains that you might decide to specify if you took a sort of formal academic behaviour change approach. And to me, what that says is, if you involve the right subject matter experts in delivering change, you'll come up with really comprehensive and quality recommendations that can help support implementation. So where do we go from here? Well, we were keen to trial audit and feedback, and we actually have done a national audit of 107 hospitals supported by the British Association of Urological Surgeons. And the value here is, if we look at those 12 recommendations that we produced for bladder cancer care, we can give data back to hospitals that says where their big carbon emissions hotspots are and what their own local priorities are. So this is something that we've been testing out, this audit and feedback approach. And if we look at 7 different hospitals that submitted data, you can see that their individual carbon fingerprints, as we called it, are very different between sites. So that's really the case for not just producing national recommendations, but producing local data to understand what the opportunity landscape looks like to best decarbonise your care. And so we've given this data back to hospitals. What we're hoping now is that that's going to feed into their green plans, which are board level signed off plans produced at every hospital across England, which outlines exactly what they're going to do to work towards their net zero goals. So just to conclude, what are my thoughts here? Well, I think the ELA methodology is a really useful adjunct to help us take what we know we can do at the moment but aren't doing and put that into action. What we're keen to do now is to build capacity and scale around this ELA methodology and its application in the UK NHS. We need to look at implementation to figure out where the teething problems are and how we can help unlock those. And we're really keen from a methodological perspective in the future to align and to integrate life cycle assessment methodology into what we do, and to make sure that health economics is an integrated part of every pathway that we look at, because that's clearly an important case to make alongside sustainability. And so for yourselves, what are the key takeaways? I would say have a system for when you're thinking about what you want to do in sustainability, have a means of determining what the best thing for you to spend your time on is, use data, and collaborate widely, particularly with people who really understand the clinical area or the area that you're trying to change, because those expert insights will be invaluable. So thank you very much for the opportunity to talk today, and happy to take any questions.
Thank you, Joe. Thank you. That was terrific and really informative, and congrats on the work that went into developing a new methodology. That's no small feat, I'm sure. We'll have some time for questions later on, so please, audience, if you have any questions for Joe, and specifically for Joe, please share them now or throughout the call, and make sure that you let us know it's for him. Thank you, Joe. Now, I would like to welcome our next speaker. His name is Johnny Groom, pediatric anesthetic consultant and lead for Greener Theatres at Barts Health National Health Service Trust, associate medical lead for sustainability at Nuffield Health, and honorary associate professor at the University College London. Welcome, Johnny.
Brilliant, thank you so much. So I've been tasked with talking to you today about anaesthesia and perioperative medicine and the sustainability impacts of that. Can I confirm you can hear me and see my slides?
Johnny, I'm just going to interrupt you. I'm finding your mic's a little hard to hear. Is there any way you can adjust a little bit? Sorry for my camera.
That's all right. Can you hear me now? Is that a bit better?
Yeah, that's much better. Thank you. We didn't quite hear what you said before, so feel free to repeat if you want to. No worries.
Grant, I just said, so lovely to see you up there. I'm here to talk to you about anaesthesia and perioperative medicine and the sustainability impacts of that. So we're going to quickly go through climate and perioperative risk, decarbonising anaesthesia, and then how you can enact change within your institution and be real advocates for the patients we care for. So, as I'm sure many of you know, climate change is really bad for your health, and all of this has significant impacts on the perioperative care pathway. So climate change is making more unhealthy populations, and we're seeing this now with the patients that we anaesthetise, with people coming in with much worse respiratory conditions, especially during heat waves, which really impacts the perioperative care that we want to deliver to our patients. And I want to focus in on some specific key areas, as I'm sure many of us across Europe have been realizing recently, the effects of extreme heat. But the patient effects that we can experience during the perioperative period can be quite significant, be it from dehydration or electrolyte imbalance if not managed properly. Hot patients tend to be more vasodilated, so they get more susceptible to low blood pressure, poor perfusion, and it puts a real strain on the hearts of vulnerable patients and high-risk groups, such as the elderly, patients with pre-existing cardiac disease.
Sorry. Yep. Pardon me. I realize I'm intruding myself, but we don't see the slides switching, so I think your slides aren't on full screen. We see the full layout, so I want to encourage you, if we can take a brief moment. Apologies for interrupting you.
No, that's all right. I'm on full screen my end.
There it is. Anything? Yeah, now it's much better.
That's
so
great.
If you can the slide you were on and continue, my apologies. I'll get off stage now. Thanks.
That's quite all right. So yeah, I was briefly talking about the health impacts of climate change and how that affects the perioperative care pathway. In relation to heat, as I've discussed, our patients are particularly susceptible when they're undergoing surgery. We need to also think about the risks of what's happening once you've put an incision in a patient. You know, one of the big risks post-operatively is surgical site infection. And papers have noted there's around a 39% increase in surgical site infections in warm environments. But also we need to think about the environment that the patient is having the operation in during a heat wave. A lot of the time our hospitals are unable to deal with this massive increase in heat burden that they are facing. We're finding poor staff performance due to dehydration and fatigue. We're finding our air handling units being unable to bring temperatures down to acceptable conditions. And in fact, during the last heat wave when I was working in the UK, our theatres were going up to around 65% humidity, temperatures of around 32 degrees. And we're often faced with the question, is it safe to continue to operate in these conditions? When we need to consider the damage to the equipment that we use, the drugs, which all have a top temperature range of around 25 degrees, and we're frequently now operating in environments hotter than that during these heat waves. We've seen data center failures leading to IT outages, which massively affect our digital dependent hospital systems. And in fact, the UK Health Alliance on Climate Change reports that over 90% of NHS buildings are now vulnerable to overheating. And I think many of us have lived that over the last couple of weeks. So what we need to do to embed resilience within the patients that we see on a daily basis is make every encounter count. We need to talk to our patients about climate change so they can advocate for their own health and speak truth to power when it comes to how the climate is affecting their health. We need to make clear perioperative plans that take into account this increased burden on health. So we're now being much more liberal than we have been in terms of our starvation protocols for patients, allowing patients to sip water right up until the point where we send for the surgery. And we also need to consider, should we be admitting these patients preoperatively for hydration? And then post-op, is the safest place for this patient going to be at home, in a home that's poorly cooled? And then we also need to make sure that our hospitals have these resilience plans in place to deal with some of the chaos that can ensue. So let's talk about decarbonising anaesthesia. We know the NHS carbon footprint has changed over the last couple of years as we've massively reduced our emissions by about 14% over the last 5 years. And this has largely been led by staff-facing projects, namely, and anaesthesia has been a real leader in this, with our overall carbon footprint of inhalers and anaesthetic gases reducing from 5% of the overall carbon footprint to 3%. And we can see this is our overall our overall carbon footprint from anaesthetic volatile gases, which has decreased significantly. And this has largely been driven by reducing the use of a potent greenhouse gas called desflurane. The clinical benefits weren't really there in comparison to sevoflurane, our most commonly used anaesthetic gas, and that has led this huge decarbonisation. And this has been done using digital dashboards throughout the NHS, where hospitals have been named and shamed if they're using them. Now, some of these hospitals here are still licensed and able to use it for certain conditions, but this is the approach that was taken by the NHS, and then legislation followed. But there are sustainable alternatives to keeping a patient asleep. Firstly, we can make sure that our flows are low, and we're using lower carbon anaesthetic gases like sevoflurane. But we don't need to use anaesthetic gases at all. We can keep patients asleep using medicines intravenously like propofol. We can avoid general anaesthetics by doing nerve blockades and putting local anaesthetics in wounds, and just doing simple IV sedation techniques as well, as described by our previous speaker. But there's also technologies available now to capture anaesthetic gases. There's still legislation in play. They're still working on legislation here in the UK about the reuse of those anaesthetic gases, but having them captured and stopping them being put into the environment where they have their significant greenhouse gas effects does have a big effect on reducing the carbon footprint, as demonstrated in this excellent paper written by Tom Pearce and his team. I can see Tom's here on attending today. Lovely to see you. And this is a fantastic paper that took into account vapor capture technology and also really highlights the significant carbon difference between certain anaesthetic techniques that we use. So there's another really great paper that Tom and Cliff Shelton worked on, looking at the paediatric population, which is slightly different from the adult population, because what we tend to do in some cases is put a patient to sleep using anaesthetic gas instead of doing an intravenous induction. And that has huge flow rates and a huge carbon burden, as we can see here. And interestingly, a lot of our practice prior to this paper being released would be to do a gas induction on a child and then move over to total intravenous anaesthesia, thinking that we're going to be doing our bit for the planet. But this paper highlights that it's only really beneficial for longer procedures. So for a child weighing, say, 5 to 20 kilograms, the procedure really needs to be an extent of, needs to be more than 77 minutes. And for a child weighing 30 to 50 kilograms, more than 105 minutes for that carbon benefit to be yielded. But of course, there are many benefits to different techniques that we use. So nitrous oxide, another potent greenhouse gas. We've really changed the way that we utilize this within the hospital. Now, we've seen it's reduced within clinical practice, within anesthesia, but we didn't really see our overall ordering data reduce. And it took an amazing pharmacist in the north of England called Alif Shakira to realize that actually what was happening, and the biggest wastage from our nitrous oxide was coming from leaks within our pipe network and cylinder systems going out of date, leading to vast majority, up to 99% in some cases, of this drug being wasted before it even reaches the patient. And again, the NHS dashboard has been tracking this across, and we're starting to see a gradual decline in our emissions from nitrous oxide. Other ways within anesthesia we can reduce the carbon footprint is reducing the intravenous drugs that we give, instead giving oral drugs pre-operatively, as we know oral drugs have a much lower carbon footprint, as demonstrated in this paper here, looking at paracetamol, where we can see oral tablets have a much lower carbon footprint than their IV counterparts. So waste is obviously a big thing. We make a lot of waste within the operating theatre space, and there's many projects which we can do to reduce the carbon footprint, making sure that we recover as much as we use and go into reuse. And then if we do need to throw it away, make sure we're putting it into low carbon health streams. But we need to start looking at how we can reduce of the stuff that we use. And simple things like Yanker suckers used to suck spit and vomit out of the patient's oropharynx. Many times we'll see 3 of these used per patient episode, when in reality, that piece of kit can follow the patient from the anaesthetic room to theatre to recovery, reducing the carbon footprint of that item by a third. We now have guidance out saying that we don't need to be getting fully sterile to perform spinal anaesthesia, and this is based on evidence. And again, reducing the carbon footprint of that procedure by reducing the sterile gowns that we put on. And again, looking at anaesthetic breathing circuits, extending their use to 7 days following guidance, again, will reduce the carbon footprint of the work that we do. But again, we now need to move away from single-use instruments such as laryngoscopes, which were bought in on a poor evidence base with poor evidence backing them up. And we can see from fantastic life cycle assessments from the likes of Jodie Sherman, I'll share these slides with you in detail later, when we get sent out to you, but we can see that the carbon footprint of, say, a single-use steel handle or blade on a laryngoscope has a much higher carbon footprint from a reusable one, taking into account the reprocessing and repackaging. And there's so many pieces of kit that we can move over to reusable, from tourniquets, textiles, theatre caps, and the like. We need to talk a little bit about energy. Energy has been a huge burden to the NHS from a financial perspective over the last couple of years, and we know that the large minority of energy within the hospital comes from the operating theatre. And I would say around half of that comes from medical equipment. But in reality, if we're looking outside of the energy that actually is used within the operating theatre, I would say about 3/4 of that, based on evidence, shows that that's coming from the way that we handle air within the operating theatre. So we've rolled out things like greener theatre shutdown checklists, encouraging our staff to turn things off out of hours, but now also following specialist ventilation guidelines within the NHS, we're getting our teams to turn off our ventilation systems out of hours. Because in reality, whilst we think Monday to Friday, 5-day operating implies 71% operational use, when you take into account an 8 to 8 start and finish time, in reality, that's 35.5%. Yet most of our ventilation systems are running 24 hours a day, 365 days a year. And the carbon impact of that is significant, and the cost impact of that is significant. And we've recently released a paper demonstrating that. Now, for the NHS alone, if you were to turn off your ventilation systems out of hours, that would save the NHS upwards of £90 million per year. And from a carbon perspective as well, you're looking at around 30 tonnes of CO2 per year, depending on ventilation modality and energy source. And finally, I know I'm going a bit over here, how would you go about these projects? Well, I would suggest setting up an interdisciplinary working group, track your projects, and work with academics and with industry. They have different access to ideas and funding and different time constraints, and they can really support clinicians in this transition. Level the playing field. Sustainability is not something that has that same ghastly hierarchical structure that medicine does. It is a much more, you can get really useful information from people, such as medical students, nursing staff, that can be so incredibly additive to this. So let's take a level approach and be stealthy. Don't necessarily call it a climate reduction project, call it a cost improvement one, and you may get more people on board. There's fantastic resources out there to look at within surgery. And just remember that if we decarbonise healthcare, we may reduce about 4 to 5% of net emissions, but think about the impact that we have further afield, because we touch 90% of global supply chains. So if we start to impact the supply chains via things like the net zero supplier roadmap, making companies like Philips and Siemens decarbonise, you're not just impacting healthcare emissions, you're going further afield. And I'm going to stop it there because I'm overrunning, and I look forward to the panel discussion at the end.
Thank you. Thanks, Johnny. That was terrific. And sorry again for interrupting you, but it was worth it
That's
to
right.
get fully because they were super informative and some great graphics. I really appreciated the tips that you gave. They were very specific, and I like to be stealthy because it made me go like, what do you mean by that? Tell me more. But it makes total sense. We often hear people refer to the triple bottom line approach as well, and like making sure that you're clear on all the climate solutions offering way more than just a lower carbon footprint. So thank you for your insights, and we'll see you shortly for the panel discussion.
See you in a bit.
All right, moving to our next speaker, I'm pleased to now introduce Rory Turnbull, Sustainability Research Lead at Sustain and Postdoctoral Research Fellow at the Institute of Design, Robotics and Manufacturing at the University of Leeds. I realize I don't explain what Sustain stands for, but I'm sure I'll leave that to you, Rory. Welcome to the stage. How are you?
I'm good, thank you. Thank you for having me. Hopefully you can hear me okay.
Yep, I can hear you. I can see your slides, so I'm going to leave the floor to you. Thank you.
Amazing. Great. So I'm going to speak about sustainable surgery by design. We're kind of looking at how we can make improvements and also highlighting some impact we've managed to have locally in Leeds. And then I'll go on to talk a bit about Sustain at the end and how we're looking to apply these methods. So the first sort of bit of this presentation is around tray rationalization. As I'm sure many of the clinicians here will understand, over time, there's a general increase in the number of tools in surgical trays, sometimes down to preference, or maybe a tool has been used consistently, so it's added by the prep team. But while there's an easy path for tools to be added, often it's more difficult for them to be removed, as often people want them there just in case. But there are cost and carbon implications due to the sort of sterilization process, and then potentially waste implications. Tray rationalization, while we're interested in what's on the tray, we're also interested in what's not on the tray. I'll run through an example in a moment, but looking at where we can change from a potentially single-use item to a reusable item. So in 2021, as part of the Green Surgery Challenge, my colleagues ran through this study where they took a laparoscopic appendectomy, I believe is the phrase. But basically, they in a cadaver lab, they ran through the full process, setting out all the items that were used. And you can see here in this image, all the single-use items laid out on the floor, with the reusable ones on the tray. And the goal here was to track exactly what was being used so we could identify which items can be removed entirely because they're just not being used, and where we can shift from a single-use item to a reusable item. And that's what we have in this image. So you can see that image on the bottom is the single-use items that are remaining, which is a significant change from what you can see on the left. And at the top, that is the new green tray with all the reusable items. And they went on to win the Green Surgery Challenge, and have had a couple of publications that have come from it. And they've since then been looking at how they can implement this on a lap Coley tray. So since the Green Surgery Challenge, we want to implement as many of these changes as locally as possible. So they procured 8 of these green trays and introduced them into the theatres. This picture shows one of the trays, and that includes the metal containers. So we're not using the blue disposable wraps. And then there's also, because of the items they were able to remove in the trays, they could then fit items like metal kidney dishes and galley pots, which are in every surgery but were disposable before, so generate a lot of waste over time. So during each prep session for a surgery, there is a discussion on which tray to be used, with the green tray being an opt-out option. I'll discuss in a moment, but there are situations where the green tray isn't used. But I will share some of the impact we've had so far. But the main thing is they've worked out that we're saving around £10,000 per year. And this is for a single theatre team and single operation. So there's potential for these tray rationalisation processes to scale quite significantly in the NHS. So to be able to identify which tools are and aren't being used, they did the trial run in a cadaver lab, but you need significantly more data to be able to understand which tools are actually being used, and from a range of surgeons and surgical teams to sort of build up that picture. So they observed 70 procedures to build up this data set across 3 theatre suites and 4 subspecialities. And then this generates this heat map of your kind of tool sheets. And you can see here there's lots of those tools where they sort of in the red, where they haven't been used at all during surgery, or maybe they have a very low use rate, at which point we can move them into a single pack sterilisation, so they don't have to go through sterilisation every single time. So they're still available when they're needed, but for the majority of cases where they're not used, they don't have to go through that sterilisation cycle again. And this was done with NHS England and has gone on to inform the Innovation Agency report, which is here around surgical instruments rationalisation. So for anyone interested in how they can implement it themselves, this is quite a nice resource. So in terms of the impact, the green tray was introduced in 2022 in May, which is why you see this sort of lower uptake in that year. But through collaboration with B. Braun, we've been able to access the data on tray utilisation based on how often it's being returned to them for sterilisation. And you can see here we've got a really good uptake of the green tray, sitting at about 85%. And I believe the data here for 2025 puts that a little bit higher, sort of in the 90% range. And having looked back through the data, they've identified that the patient sort of history sheets, we've identified that the 10% or 15% where the green tray isn't being used is because it is a more complex situation where maybe they've gone from a laparoscopic operation and then gone to open. And so they've had the more extended trays available as well. But a key part of getting this adoption, we think, is from the very start of this process, the entire theatre team was engaged in developing the green tray. And so when asking which one should be used, everyone is on board with selecting the green tray, which has been really, really useful. One of the interesting things we've actually found, having been doing a bit of a deep dive on the sort of tray rationalisation data from B. Braun and sterilisation cycles, is your standard sterilisation cycle gets returned in around 7 days, but there's a large case of people putting in priority requests. And because we can track when a tray has then been returned, we're able to identify that, in fact, most of the time, trays aren't then being used straight away, which for the priority case, you would hope they would be. And so it's a big indicator on some further cost savings that could happen here, where we're paying a premium to have these returned within, I think it's around 6 hours, but then they go and sit on a shelf, and it's more around people worrying they're not going to get them back. Whereas we have fairly solid evidence that they are getting the trays back on, and there are trays available on time. So there's a bit of work around that in terms of the sort of human factors side of things and decisions that are made. So in terms of what next for tray rationalization, this process was very manual. There's a lot of talk about digital, whereas we would hope to move towards more an automation-based approach, mostly because you're still creating new processes that someone has to do if you're marking things digitally. Whereas if we're able to do this in the background using technologies such as computer vision or RFID, we remove the work burden, or don't create a new work burden on a strained sort of NHS staff. So we're currently looking at 2 methods. One is computer vision, which is a fairly portable setup. And then you have larger sort of systems that are integrated into the theatre, which would be RFID. But this is generally a bit more expensive in terms of the infrastructure set up. I'm going to quickly go on to Sustain in my last moments. So Sustain is the sustainability and simulation theatre for academia and industry. It's a high-fidelity mock operating theatre focused on human factors and sustainable innovation. And the idea is that people can come into Sustain and test new innovations in a sandbox environment without any patient safety concerns. And it's currently being built at the Leeds General Infirmary. And this will be a bit of a test bed for us to experiment with these new tray rationalization methodologies. And I should also say before I finish that it's with the Department of Health and Social Care and the Design for Life roadmap. I think I have run out of time, so I'll stop there. Yeah.
Thank you, Rory. I appreciate that, and that you're keeping an eye on the time too. I didn't want to interrupt you, and yeah, to stop learning about Sustain. It's a terrific initiative, and how cool. I think experimentation is important, and being someone who works on a computer, I have all the freedom in the world to experiment with no consequence to anyone. So in order for everyone else that works in your fields and the medical field to be able to develop and innovate, that kind of environment makes total sense, because yeah, how else are you supposed to come up with new solutions and see how that affects patient care? So thank you for the work you do, and thank you for keeping an eye on the time. Appreciate it so much. Right. We will now move on to our next speaker. So I would like to introduce to you all Federica Pirro. She is the president and legal representative of the Italian Center for Sustainable Healthcare and an operating theater nurse in Italy. Welcome, Federica.
Hello. Hi, everyone. Thank you for having me. Can you hear me?
We can hear you indeed, and we can see your slides. So I will get on stage now and see you. Thank you.
Thank you so much. Yeah. So as Hope said, I'm a nurse. I have been working in the surgical field for about 10 years between Ireland and Italy. And in 2022, I came back to Italy, where with the help of colleagues and friends, we started the Italian Center for Sustainable Healthcare, which is a non-profit organization that's been dedicated to guiding the Italian healthcare system in moving towards a more greener, sustainable healthcare, trying to mostly introduce knowledge, training, and some research on sustainability and making it available for the Italian setting, and promoting as well mitigation, adaptation policies and processes, and hopefully projects in order to realize this very needed change in the Italian healthcare system as well. So we feel that's very important because compared to other countries, like for example England, Italy comes a little bit behind. We all know that the healthcare sector is responsible for a lot of CO2 emissions, and especially operating theaters are very pollutant, but there is not really available and official access on the Italian situation. We do know that Italy has a significant volume of surgical activity, and also we know that Italy is one of the countries in Europe that's been most affected by climate change. But even so, we still lack a national strategy to decarbonize the healthcare system, and something is moving right now. There has been a little bit of a change. There are people that are becoming more interested and more active on the topic. But for right now, at the moment, we only have individual institutions and kind of spotting initiative that are trying to do something. So as an organization, we feel that we need to try to help and address the situation. And so we have been starting providing knowledge and training available in Italian in order to make people who are not English speaker, for example, to have this knowledge available to them as well. And we have working in collaboration with Healthcare Without Harm as well in realizing some of the resources. And one of the things we have been working right now, and has been one of the main projects we are doing now, is the Italian Green Theatre checklist. So as I said, Italy comes a little bit behind other country, but sometimes that's actually, an advantage, because we don't need to start from scratch. We already know what we should do. We already know there are available tools and items that we can use. And for example, that's the case of the Green Theatre checklist. So the Intercollege checklist has been created in 2022 and reevaluated in and revised in 2024 by the Royal Colleges of England, of Edinburgh, of Scotland, and I think Ireland as well. So what we did, according with them, so asking authorization, of course, we have translated the checklist into Italian, and then we had make just also a cultural validation of the Green Theatre checklist in order to make it useful in the Italian setting. So this process has been done in 2024. It's been a very rigorous process. There has been a literal translation and also the cultural adaptation going back and forward from the English and Italian language in order to make it as much as possible rigorous and similar to the original version. And also it's been validated from a group of experts just to confirm that the tool was the higher levels possible. The checklist itself keeps the same structure of the original one, so it's divided into 4 sections: anesthesia, preoperative, intraoperative, and postoperative settings. But also there is a manual for user that's been that we have created in order to explain every one of the item of the idea that's been that has been validated in order to make it greener surgery. And all of this has been also validated into the Italian to make sure that it relies to the Italian law and to the Italian setting, because there are some things that are not usable in the Italian session. And we have also worked on partners, Italian partners like CERT, which is the anesthesia society, or for example the Choosing Wisely Italian movement, in order to make it as useful as possible for the Italian country. We realized this in 2024, and then we tried to do a pilot study just to make sure and try if actually we could use the checklist as a tool, the first tool available in Italian, to assess and also try to implement projects on sustainable theatre. So we use the checklist in 3 different hospitals. They are all under the same azienda. They are in the north of Italy, and they are 3 country hospitals, but together they have 12 operating rooms, and they cover more than 300,000 inhabitants. So they're kind of a big area. What we did, we realized 2 training events in which all the healthcare professionals for those operating theatre were invited. It was nurses, healthcare assistants, management, everyone who wanted to come was invited. And then we proposed the Green Theatre checklist to them, and we collected different answers, and we asked them to try to imagine one of their average day of work and try to say what we were doing already and what we were not doing already by using the checklist. And it was just an exercise, but it was really useful, because what we realized that we were already doing something that was actually good, so we had a good start, but also there were a lot of things that we were not doing, and then we could actually try to implement new projects on this. So just to give you an example, we realized that there is no nitrous oxide used in none of the theaters. So for example, we were really good in that. And also we were really good in providing local and regional anesthesia when possible, and avoiding general anesthesia altogether. And also the 3 hospitals were all renovated just a few years ago, and so we also had some unoccupied strategies already in place for the scavenging system and the ventilation system. So we realized, for example, there was something good we were doing already, and we didn't assess it before. And then we realized there was, of course, a lot of things that we could do, and there were a few areas, I just made a list here, of things that we could work on. For example, we were still using desflurane, and we were not using pre-filled syringes, so we had a lot of pharmaceutical waste that we could try to address. And also, we were very few reusable sterile drapes and PPI working, and we were not doing very good in disposing properly our waste. So based on this list, we tried to analyze what we could try to do by using some simple tool, for example, the impact and feasibility matrix summary, where we identified the possible sustainable initiative that we could implement, and then we tried to divide them by what was easier to implement or what we felt was a little bit more difficult. I don't know if you can see that, but we just tried to divide the idea we had, and then we started for what we thought was going to be easier. So, for example, one of the first project we realized were the anesthesia ones, because we involved all the anesthetists. We did a little bit of an education session and also a questionnaire, and tried to understand who was available in stopping using desflurane. We had, for example, a very great response, and we realized that more than 90% of the anesthetists who were using desflurane were just doing it by habits, and they were actually happy to stop using it. So this was the first project we did. And when the European law came on in the January 2026, asking to stop using desflurane, we were straight on board, and since then we haven't used it at all. We have completely dismissed it and took the vaporizer off the theater, and nobody has asked for it ever since. The other thing we realized is, for example, we could work on the water usage, because in a lot of theaters we already had all the technologies to make it easier to avoid wasting water. And also we already had the alcohol-based gel for surgical hand rubbing protocol implemented, and there was just a few knowledge about it. So we realized just talking about it and make it more available, and just working on education was a good point to start. And now we have implemented, I don't have data yet because they're all ongoing process, but I would say about 30-40% more of alcohol-based gel surgical hand rubbing usage than before. And other things we are working on, for example, that all been driven by the checklist, has been the drug waste reduction. So we started introducing pre-filled syringes that we didn't use before. And also we have been working on introducing reusable items where possible, substituting single use. So far, for example, we have introduced the video laryngoscope blades that were single use before. Now we use reusable ones that can just be cleaned and use them again. And the same thing is doing for the thermal probe. So we used to have single use thermal probe, and now we have 5 reusable ones that we can just wash and use it again. And we are almost completely avoiding the single use ones. There are other projects for disposable that we are implementing. So we are working on reintroducing, for example, glass waste that was not done at all before the assessment that we did. And also we are working on reducing the amount of waste we produce altogether by introducing custom packs and reviewing surgical kits. So we are doing a big project in our CSDC department where we are reviewing all the sets we are using for instruments and trying to rationalize all the trays and trying to avoid everything that's not necessary. So all of these are all ongoing projects, and for some of them we have some data, for others they are not available yet, but just to give you an example here. For example, by introducing custom packs, we realized we were able to reduce more or less 90% of the package waste that we were producing. And also we had a lot of benefit, and as we already know, there can be in reducing also the financial expenses, because we are avoiding a lot of waste that needs to be discarded and we need to pay for that. But also we are reducing the amount of errors and accidental contamination that we were doing by opening, for example, the wrong item for the surgery. As well, with the green anesthesia, we have, as I said, completely stopped using desflurane since January 2026. And we also have been able to reduce pharmaceutical waste by introducing, for example, atropine syringes. That's just one of the theater. In 2025, we went from 1,200 ordered to only more or less 100 ordered. So there's been like 90% reduction as well here. And most of them we were just, as you know, prepared and then throw it away without never being used. The Sustainable CSSD project is ongoing, so we don't have data yet, but they will be available soon. But we did a great job in involving also some of the wards, for example, the ED department, and the obstetricia and gynecology department in reducing the amount of unnecessary surgical instruments they were using as well. So we are kind of confident that we're going to have great results here as well.
Hey, Federica.
Pilot, yeah.
Sorry, my apologies. I'll need to stop you there, just so in the interest of time, because we've gone over the 10 minutes.
Yeah.
That said, I want to share your slides as well after with the audience, or if you want to wrap up just on this one and then we can transition.
Just wrap up. The last slides is here and say that the pilot study has been successful. So we are moving from a pilot study to a multi-center study where every hospital in an operating theater that wants to will be able to enter the study, and they will be able to use the Green Italian checklist and try to assess their own situation, promote sustainable practices, and hopefully we will be able to work together on this and create a national scenario of hopefully new scenario as well. That's it. That's the last slide. Yeah.
Cool. Well, thank you. Appreciate it. Sorry about that. In any case, I really appreciated the matrix that you had. It's a useful way of assessing sort of what makes the most sense, what the quick wins are indeed, but also what's more possible long term. Also, already the amount of data that you just had on the effects that it's had is fantastic. So thank you for sharing that, and we will continue with you in the panel discussion.
Thank you.
Thank you. Now I'd like to welcome our final speaker to the stage. It's Kieran Ryan. He is the Managing Director at the Royal College of Surgeons in Ireland. Welcome, Kieran.
Thank you, Hope. Is everything, you can hear me?
I can hear you. I can see your slides shared sort of individually, but I'm not seeing the full screen share yet. If you can get that one up, then we can see them properly, and then I'll get out of your way.
Just one sec now.
Take your time.
Yeah,
Thanks everyone for your engagement in the chat. Yeah, that's perfect. Looks good to me. Okay, over to you.
Great. Thanks very much. Good morning, everybody. I absolutely want to compliment all the previous speakers on such amazing leadership in this area, and some fantastic examples of what can be done and what can be achieved if people actually start using the evidences there. So RCSI, and I'm glad to see Federica is a graduate of RCSI, so we're spreading the word everywhere. We're basically responsible for the delivery of surgical training standards and practice in Ireland. and we're also Ireland's largest medical school, and we have medical schools across the globe as well, and so we've quite a global reach. We try and impact, I guess, mainly the education, training, and research, specifically in healthcare. So this is our main focus, and how we improve basically human health through our endeavours as universities. The college ourselves, we've very much put a focus on our core mission of education and training and research. And we will focus very much on how do we use these areas to influence the improvements people need to make in their day-to-day practices in healthcare. So we're very much focused and kind of aligned with the Sustainable Development Goals from the UN, and where we can work on that. And Sustainability and Climate Health Committee was formed in the college and university, and where we're on our own journey as an institution to go for net zero by 2030, or at least reduce 50% of our carbon emissions by 2030 and head for 2050. That's aligned with the Irish government's goals there. But primarily we look at education. So at an undergraduate level, looking at the new generations of doctors, nurses, pharmacists, physios coming through the system, we really look at our education curriculum and see where we're building in climate health into our education programs to ensure that there's a basic knowledge. And as the cover slide said, we're looking at this as a core competency, not just of surgery, but of obviously any medical endeavour, the understanding of sustainability and the need to address healthcare within the climate change that's going on at the moment all over the world. We have to look at that. And I guess there's two prongs to it, not just the reduction of carbon footprint and greener and more sustainable delivery of healthcare, but also actually understanding how the climate change is affecting actual diseases, and how we need to adapt our health systems to deal with these new changes to the health presentations we're seeing in our system. So they go hand in hand, these things. In terms of postgraduate training, this is mainly my own area, where we were supposed to be responsible for the delivery of the National Surgical and Emergency Medicine Radiology training programs. So we would have about 650 residents across the Irish hospitals in surgery alone, and it's theirs are going to become the new consultants and the new leaders of surgical departments and practices as things go through. So again, how are we shaping their thinking on this area? So we put a lot of work into with our own, again, in colleges we love a committee, and we got our council very much focused on that. And this is very much about bringing that leadership and bringing that change of culture and thinking and advocating on where surgery needs to change, and building upon all of the individual projects that people are leading on that we heard earlier on this morning. So we developed an online CPD training program for our trainees. Very simple, very straightforward, accessible introduction into the whole area of sustainable healthcare, sustainable surgery delivery, all based on what you've heard up to date, the intercollegiate green surgery checklist and all the evidence base that's behind that. We produced a kind of a guidance document that a policy essentially for the Irish surgical community, and both use that to influence the practitioners, but also to influence our health system and the health system leaders, how this is important and the approaches that we can take to that. And essentially, like, you heard earlier, building on the 6 R's of sustainability, so rethink, refuse, reduce, reuse, repair, recycle. We've got some amazing examples from people there before. All of these things are within the Green Theatre checklist. And as Frederica mentioned there's no point in reinventing the wheel when a lot of this work has been done. The key is to build upon it as much as possible. So the approach we were kind of looking at in RCSI was, well, how are we going to roll this out across the health system and not just individuals and pockets of activity, and where we can sustain our role as kind of, I suppose, the national training body and education, university, research, and development of standards. One aspect we have a very big privilege of here in Ireland is a bit like what we heard from Joe earlier on the GIRF programme. We have a similar programme in Ireland where the medical representative bodies essentially work in partnership with our health service executive, which is the Irish equivalent of the NHS, to shape care pathways. And a key component of that is to look at efficiencies and greener approaches and more sustainable approaches to healthcare. And a bit what Joe touched on there, that stealthy argument, I think, which is wonderful, in that if we can sell it to the accountants, we might actually make some progress. But interestingly, efficient care is green care, because the less we use, the less waste, the less more use we make of the resources we have, the better outcome for everybody. So we worked on it basically, how do we harness all of this standards and evidence-based and information, and try and set some guidance for Irish hospitals and surgical departments to kind of help get on this journey and start benchmarking each other where they are, and understand again setting standards where the priorities should be set for each individual hospital, because each hospital has a different level of resources and challenges and issues and geography and everything else that goes with that. So there isn't a one size necessarily fits all, but there is a set of standards everybody can start focusing on. So we worked with the Health Service Executive. We got a grant to develop a Green Theatre accreditation scheme. And if anybody knows surgeons, they love a competition. And so therefore an accreditation award is certainly a good driver of their focus on being the best among their peers. So, as you know, we've heard this before, the operating theatre is, of course, one of our most carbon intense areas of our healthcare systems, and hence the Health Service Executive supported us in this project, which is now about to roll out. And again, I'm grateful for our Health Service Executive and the funding and the support that's there, and my colleague Roisin Breen, who I think was asked to go on this as well, is driving that whole climate action activity for our health services here. You've heard already, energy, anesthetic gases, waste generation, these are our key focuses and key areas that people are working on, and some amazing examples there given already on that. So our Green Theatre accreditation scheme, so basically it's a structured framework based on the evidence basis there, and it's developed really to support and recognise hospitals and teams in delivering a more environmentally sustainable operating theatre. It's based on the Green Theatre checklist and all of the evidence base behind that, and it provides a more measurable evidence-based standards approach to greener surgical care. Applies to all specialties, and we've had significant involvement from our colleagues in the College of Anaesthesiologists in Ireland, and again nursing colleagues we've had around the departments there as well, and certainly it's individuals like Frederica, who are the backbone of our surgical teams and operating theatres to actually drive all those changes there. That's what we're trying to help and support. It's based on the checklist, which and it's recently been updated and will constantly update itself as the evidence gets there. It's interesting, I remember maybe 2008, 2009, we got the Safe Surgery checklist, and that was driven by the WHO. And so, checklists, it's not a tick box exercise. It is actually an evidence-based zoning down into the things that if you did them, they'll work. And it's back to that Pareto principle that if you want to get the 80% maximum funding of 20% of the things we do, will deliver 80% of that impact. And the Green Theatre checklist acts a bit like that. It saves us a lot of time in trying to figure out, well, what should we do? Well, let's just go to the checklist. If we start implementing some of this, we might actually make the impact we're looking for. As I mentioned, we look at this both kind of bottom up and top down. So bottom up, how are we going to get individuals at a local level, education, training, support, advocacy on various things that they can do at a local level? But that only works when you impact on the top down piece as well. You have to impact on the models of care. You have to impact on care pathways. Again, we heard great examples there from Joe earlier on. And you have to be able to impact that. And that's not easy. At a systems level, dealing with the funders, the commissioners of care, the chief executives of hospitals, hospital boards. Again, it's getting into what are the drivers that they look for that would make them interested and supportive of these issues. I think at individual level, everybody's worried about the climate. We see the horrendous things going on in Europe at the moment. And so we see at individual, but when you get into institutional level areas, there are different drivers, different things driving priority. So that has to be thought about. So when we looked at the scheme, again, we set out very much goals, mission, vision, all the usual things you'll see in any scheme, based on these 10 pillars, mainly based on the anesthesia checklist, but we sort of broke them out a little bit more in order to highlight some very specific areas based on feedback from our colleagues in operating theatres in Ireland. So anaesthetic sustainability, surgical prep, intraoperative equipment, post-op sustainability, governance and culture, sustainable procurement, waste reduction, efficiency, resource, performance, and manual monitoring and feedback. So these are the 10 kind of domains that the framework works on. You heard things like, procurement, and I don't know what other systems look like, but in Ireland, it's very much a centralized procurement thing. So, our hospital procurement managers have some discretion, but not a lot. It's set at national level. These kind of national deals are done with big suppliers. So not easy to sometimes get the impact you might think you'd like. People can give you lots of examples. If you bought this and instead of that, you save this following and it's better for the environment. Yes, but if they're not on the list of suppliers, we can't purchase from them until there's some big change. So these are challenging areas, and we had to understand, how do we get an accreditation scheme off the ground within the capabilities of people who are working on the day-to-day job. And their day job, by the way, is the provision of surgical care. So, green agenda is on top of that, but obviously you've got to make it sort of slot in to how the day-to-day thing will work. The steps to Green Theatre, much like any other accreditation system, self-assessment is key, planning, implementation, review, external review panels to give kind of that objectivity to it, and then the award based on your achievement against the standard set in that particular point in time. We try and do it as electronically as possible so that it's easy and people can upload documents and get through it. And one of the key elements we said we need to do as well as part of the pilot and the development of this was not just tell people what the standards are and the things they need to do, but what is the actual evidence of compliance that they can demonstrate. So what is the piece of paper, the data, the graph that you need to show the assessors or you're part of your own self-assessment that will say that you're on that journey towards the meeting the best you can within those areas. We worked on certain targets. And again, because everybody's got a different baseline, you can't set absolute targets, kind of pass, fail. You're trying to bring everybody with you. You're trying to bring them on a journey. Most people are doing the best they possibly can within the resources they have, the time availability and the priority set by the leadership in the hospital. So you're trying to get everyone to see where they are. And we kind of worked on this idea of a 3-tier system. Essentially, anybody who engages in this activity can demonstrate an approach. Am I over time now?
You are, my friend. I'm so sorry to interrupt you. And I recognize it's a chain of events here today. But we did have, that was 10 great minutes regardless. And if you're comfortable with it, we can discuss it after as well. Of course, recording will be available, but we can also share your slides if the audience wants to know more. Okay, sorry about that. That was already very, very insightful, and really appreciate how much you make reference to adapting to people's contexts and the confines of their job and their role. I think that's really important. It's easy for us on the outside. Speaking for myself too, working in an NGO, trying to support this capacity building, sort of like you are, but you're of course much closer to the field. We think a lot about, okay, how do we make this actually applicable to the people doing the jobs when they need to be obviously focused on delivering life-saving care? So thank you for that. That's a really valuable perspective that we will get into shortly in the panel discussion. So thank you for that. And on that topic, I'm going to move us into that next section with a little introduction to the panel discussion. Let me slow down. As you've all just heard, we've been very fortunate today to have a very multidisciplinary panel of speakers joining us. So far, we've heard about a range of approaches to reducing the carbon footprint of surgery, from redesigning care pathways, implementing a greener theater checklist, adapting a checklist into how we educate and accredit health professionals, and engineering innovation, circularity, clinical leadership, etc. So if any of these insights so far have surprised you or really piqued your interest or given you any food for thought, we would love to hear about it in the chat. I already see a lot of really active people, and we really appreciate that engagement, so thank you. Now I would like to transition us into the last about 15-20 minutes here, where we will have a discussion between all the panel speakers and myself, exploring these different perspectives that they bring to the table, connecting the dots between their different approaches and asking what lessons we can take back to our own organizations and our individual work. So I'd like to welcome them back to the screen: Joseph, Rory, Johnny, Federica, and Kieran. Hi all, thank you. So what we're going to do is more or less we'll ask you to stay muted if you have some background sound, and then when you'd like to speak in response to one of the questions, feel free to unmute yourself. And if you start talking and I see that you're on mute, of course, I will prompt you. But once again, thank you for being here. And also to keep things moving, as we do have a little less time than anticipated today, which isn't a problem because we were just amazed with 45 minutes of great presentations. So really not a concern. I would like to, over 45 minutes actually. I would like to remind you to keep your answers at maybe a minute and a minute and a half max, if you don't mind. So to begin, I'm going to combine two questions that I was originally going to keep separate in the interest of time, which is looking across your own work. And my name's Hope, so I like to ask about hope. What gives you the greatest optimism that meaningful change in this field is possible? I don't just mean healthcare sustainability, I mean specifically in surgical care. And it could be a specific experience you've had. I'm looking at you, Federica, for instance, working in the theater. It could also be momentum you've seen grow. It could be a shift in colleagues' attitudes. Anything that you'd like to share off the cuff that gives you a little bit of hope, it would be nice to hear. Johnny, yeah?
Yes, I think for me.
Oh, Johnny, you're having the same audio problem as before. You're a little bit fuzzy. In the meantime, yeah, there you go. Okay.
Cool.
Yeah,
sorry. Yeah, I think the thing that excites me is stuff that actually breaks outside of our silo of influence. So stuff that we spend a lot of time talking to people who are a self-interested group, who are interested in sustainability. And I think the one project that really got people in the executive side of things, like the CFO, really interested, was the energy project that we've been doing within the operating theatre, turning off theatre ventilation out of hours, because they've seen how much money it will actually save the trust. And it's just acted as a really good lever to introduce sustainability as a driving force, not just for improving the planet, but also improving their balance sheet at the end of the year from a financial perspective. And then what that has done in its own right as well is it's brought people together from healthcare estates, from academia, from industry, and from people that actually the executive branch within the hospital as well, to focus on sustainability a lot more. So I'd say that's the one, because it just from a figures perspective, the numbers are just so gargantuan in terms of cost and carbon reduction. That's probably the one that I'm feeling most hopeful about, and the fact that we're kind of just on the crest of that wave. I think the impacts that it's going to have, not just here in the UK, when you're looking at people with different challenging climates, such as, I've been speaking to delegates in Abu Dhabi, and when they're dealing with heat, we're dealing with cooling and warming air. It's just, there's different constraints, and it really plays into the resilience piece as well, as you want these pieces of equipment to work a long time, and if you turn them off, they'll work a lot longer as well.
Oh, that's such a good point. That's a great point. Thank you. Federica, I think you maybe wanted to offer something?
I just wanted to say, just if you work on something you really care about and you are transparent and you are authentic on this, that's contagious. So when we started in my hospital, nobody ever heard about sustainable healthcare. And I thought we were going nowhere. Instead, in about 2 years, we have been implementing this kind of projects. Now we have formalized a green team, which is the first one in the region, possibly the nation as well, as it is. And so you never know where you can go, but you just have to start from even small things, but you need to believe in what you're doing. And that's, I believe, the key for everything you're trying to implement. And that gives hope, at least to me. So hopefully it's the same for others.
Yeah, absolutely. I mean, it makes total sense. I think Kieran was kind to right away highlight, and rightly so, what a local champion you are. I mean, local / regional / national / international, because we at Healthcare Without Harm Europe work with you a ton, and your Italian Center for Sustainable Healthcare. So we certainly believe, as part of our strategy, that local on the ground champions like yourself are exactly what we need to get further. And I can attest personally to your enthusiasm being contagious to me. So thank you for what you do. Does anyone else want to add something on this topic before we move on? Yeah, go ahead. Thanks, Joe.
Was that so Kieran nicely pointed out the sort of need for a top-down and bottom-up approach, and I think we have the ingredients already. So we've got amazing buy-in across, certainly the NHS, and I'm sure that's replicated. And from what I've heard today, it certainly is in other health systems as well. So we've got the buy-in. We've also got a really, really strong policy framework in many countries now. Adoption of net zero targets. What we probably lack is the recipe to put it all together, and how to join the two. And we've talked about other sort of challenges that organisations face, and priorities that they have. But I think everything's there. We got to sequence things. We've got to develop methods for how we really work through this systematically to drive progress. But yeah, the buy-in is there at the top and the bottom.
That speaks very highly to the work you've done. If you've already got the buy-in from there, that's something that comes up a lot for us in our work with we have different audiences, of course, from sustainability leads to health professionals, but in general, I would say a common denominator is often the challenge of securing buy-in. Understandably, because it's not a top priority, and if you can't marry it, as Johnny highlighted, with other benefits and also make a powerful argument for why this matters for resilience and for decarbonizing, then it's difficult to be heard and really bought into. So thank you for that. Speaking of recipe, I want to move on to the next question, which was about making sustainability work indeed in real care environments, in clinical environments where patient care is evidently, obviously, always the priority and must be the priority. So I want to ask, I think you all highlighted this a bit individually in your presentations, but I want to synthesize a bit or see what commonalities there are about how we can ensure sustainability initiatives also improve the quality and outcomes of care, and how the two can be effectively really married. So is there any approaches that have proved more practical? Is there any lessons you'd encourage others to adopt? Or what surprised you during implementation about patient outcomes? Was there a result you didn't expect in a patient's well-being or recovery, or in their preoperative care, and so on and so forth? Anyone have anything on that topic? Yeah, Johnny, please.
I think before we even go on to looking forward, I think we need to look back and ask ourselves, what is the evidence for a lot of the decisions that we've made over time, and how that has been beneficial or not beneficial for patients. So if we're looking at single-use instruments, for example, a lot of that has been brought into play with a very, very poor evidence backing, and it's often been done under the guise that this is better for patients, where the evidence just hasn't backed that up. So I think we need to speak truth to what we have done in the past, because a lot of the changes we're trying to make within the healthcare system, we're being asked, what is the evidence for us? Where is the randomized control trial? We don't have time to complete multiple randomized control trials in order to decarbonize our health system. So I think we need to take a common sense approach to the situation we're looking at and ask, what evidence has been required leading up to this point, and is that evidence actually backed up?
Absolutely. Anyone else to add on this topic? Joe?
Just to engage patients and engage clinicians and the wider team who understand the context. I think having context-specific expertise is crucial, and then you can unpick a route forwards. And I totally agree with what Johnny said there as well about it's curious how we can find ourselves in a position where we feel like we need to generate evidence to go back to where we started from, even though where we've arrived that was non-evidence. It's non-evidence based often anyway. But if you talk, we've actually done work on this around looking at reusable drapes, because there are certain specialties, things like implant prosthesis insertion in orthopedics, for example. There are concerns there about the use of reusable drapes. But you talk to patients and actually you can start to understand that they have very mature perspectives on this, and they understand that not everything, as Johnny said, needs an RCT to get back. Sometimes it needs good quality operational evidence and monitoring, and that's enough. Yeah.
Absolutely. Yeah, Kieran, please.
One of the challenges, I think, is these metrics and KPIs that people keep looking for and trying to show me how we've saved money. And often it's very difficult to measure things you don't do, because probably the most impactful thing we can do to reduce the carbon footprint is to avoid certain activities altogether. And so measuring things that you don't do is really hard. So you kind of need a historical data, and then maybe show some trends later if you've actually managed to make these changes. But I think trying to describe, I think someone mentioned about getting more health economists or something involved. How do we actually measure the impact of healthcare avoidance? Because that's one of the big things we can do, is this actually, like COVID was a disaster, obviously, on many fronts, but from the consumption of waste, single use, the obsession with spreading infection, everything else, it was terrible, and bad habits have come in that we're trying to now unwind. That things aren't needed anymore on that. One of the good things it did show us, though, as well, was that actually you can deliver virtual care and stop people having to get in a car and drive up to the hospital and spend hours in parking and driving around. And actually you can do virtual clinics and everything else, which have been a game changer. And it's just kind of trying to find these nuggets and mainstream them into activity, I think is kind of some of the key areas you need to work on.
Yeah, absolutely. Yeah, please, Rory.
So I think one of the things we found it's really, well, engagement with local teams, but to really understand the pathways that you're working with. Because sometimes with sustainability, there's a big emphasis on the shift to reusable. But for an example, we found with a single-use endoscope put on a ward that actually the sort of potential cost and carbon savings were significantly higher in that specific situation. So I think there's sort of some is being able to look maybe more holistically at the kind of potential for carbon savings. And it may, in that case, we weren't really expecting it. And then as we started diving into it more, we found actually this is an instance where a single-use item is better. And so I think in terms of the kind of making a difference in clinical environments is being open to that. It's more nuanced than just go for reusable. Yeah. That said, the majority of the time, reusable is definitely the way to go. I wouldn't say that's a get out of jail free card for single use, but yeah, it's definitely more nuanced.
No, that's a great point. That's a great point. Johnny, you want to add something? You're muted right now. It's okay.
Just wanted to build on a really important point that Kieran made there, and it's about our role within the health sector. And we know that the lowest carbon form of surgical care is no surgical care at all, right? As clinicians, as people that work in the wider sector, the best thing we could be doing for our patients is using our voice and advocating for better preventative care and better environments in which to live and cohabit in. Like we need to be using our trusted voice as healthcare professionals. We are always in the top 3 of the Veracity Index, showing we're the most trusted professionals: nurses, pharmacists, doctors. We need to use that voice to make sure that people are understanding the seriousness that the situation is, but also understanding that actually treating sickness isn't necessarily the way forward. We should be promoting health. And we have a lot of, just because we're at the pointed end of that, i.e. within the operating theatre, we still have a real role to play in being that voice, I think.
Yeah, well said. Well said. You took the words essentially right out of my mouth and said them much, much better. So thank you. And Rory, I just want to highlight that's a really important point, that nuance must be a part of the conversation, and we cannot, proceed seriously and be taken seriously if we don't leave space for, as I think someone highlighted earlier, I'm losing track because you're all making terrific points, that sometimes we proceeded, I think it was Johnny, with not enough evidence in the past, and recognizing that and moving forward with intention and strategy and accepting that there's moments where something we thought would work wouldn't is more important than anything else. This year at Clean Med Europe, for the first time, at our European Healthcare Climate Summit, we had a session on failures, which was a first for us, but is an also important part of this process. Like here, we're happy to be highlighting 6 successful interventions or also innovations that are coming soon that are making change. But all of those had, I'm sure, missteps or failures before them that led to this point. So that's a really important point. And we're coming to the end, but I want to quickly ask you if you can each offer me an insight. I know it's tough to ask you to give me a bite-sized thought, but I'm going to challenge you anyways because I think you're up to the task, which is on your professional perspective, based on your professional perspective, what is the single most important recommendation you would give any healthcare professionals in the audience, or let's say people in a similar capacity to yours, which for all of us isn't providing direct clinical care, to integrate lower emission surgical practice? So it could be anything along that pathway. It could be, much as Johnny just said, focusing actually on preventative care. But, some people, if their full-time job is surgeon, maybe that's not the best use of their time or not something they can do. So based on your expertise, what would you say is the one thing you want them to take away today? Anyone up to that? Rory, thank you. Please.
I suppose starting to engage as much as you can locally. There's so many different areas that you can sort of require sort of a focus of sustainability that I'm not sure you could. I mean, anesthetic gases aside, they're a pretty heavy hitter, but there's so many areas that you could target. I think the main thing is just taking action and sort of starting to engage with sustainability, even if it's looking at, is there a green committee within your trust or something like that, so you can start engaging with it. And I think if everyone starts to do that, then you kind of start to build this momentum for change, which I think and that kind of cultural shift internally.
Yeah, absolutely. Think about the wide-ranging impact Federica's work talking about this has had from Ireland now to Italy as a great example. You're both unmuted, so I'll go to you first, Joe, please.
Okay, so both one theme, two ideas. Measure things is the theme. If you're a surgeon and you do an operation, just look at what's used and just get, either do it yourself, draw up a list, or ask one of your residents to draw up a list of everything that got used and just look down it. And I'm sure you'll find lots of things that were used and didn't need to be used. And then secondly, probably if you're thinking more broadly across the pathway, just ask some of your patients if they're willing to just tell you about what their journey was through the health system to get to that point, because I think you'll realise there are a lot more steps in that, which are often very inefficient and quite difficult for the patients, and could definitely be improved.
Thank you. Johnny, I'll go to you next.
I think one of our biggest points of failure within sustainable healthcare related projects is there is a real fear often that sits within middle management tiers of approving projects and getting them over the line. And that's due to them not wanting to sign things off, often based on a lack of knowledge. We need to make it easy for them to have that permissive nature to be able to take it forward. And I think it needs to be a collaborative approach from the colleges, from amazing organizations like GERF, to be able to say, this is safe because of X, Y, Z. We want to implement this. It's oven ready. We don't need to go via this huge governance pathway, which most people don't know where the next step is, which massively delays and causes blockers on projects. So I think a collaborated approach, as is already being done with a lot of these amazing organizations like GERF, is the way forward.
Yeah, that reminds me of what was said earlier. I think it was Joe. Again, now I lose track because it was 5 in a row, just talking about when you bring together. Yeah, it was indeed Joe. When you bring together experts in the subject matter, how far you can get. And the subject matter relating to this pathway and every care pathway indeed is not just the clinicians providing care themselves, but the whole train. Everyone has a role to play. We speak a lot at Healthcare Without Harm about healthcare personnel as well as healthcare professionals, because resilience and decarbonization depend on the engineers in the building and the administrators in the building and the custodial staff in the building as well as the clinicians. So I'll make that point as well in a complementary way. And Kieran, I will go to you next because I see you're unmuted.
Yeah, I mean, God, it's hard to get any single thing, but I think you got to look at recognition and reward, and look at the leadership that's better been taken at a local department or hospital level. Start highlighting and showcasing these areas. So a little bit more up in the communications game, I think, is important to show that actually things are being done and there are champions. And then I suppose just the other side of that then is to start looking at the back at those KPIs and metrics that maybe CEOs, hospital boards, how they're measured and their impact, and build some of that sort of performance piece that's linked to achieving sustainable practices, reducing carbon footprint in healthcare. I think if there's elements of that going in, you will start to drive certain behaviours, and it'll just come together. I think there's an awful lot of work being done already, but if we can start what measures matters, and that's what will drive certain behaviours, and then start applauding people who are taking those new projects and making sure that what they have learned is communicated across the system so that other people can adopt them much quicker, and so on. So that would be my takeaway anyway.
Terrific, thank you. And lastly, Federica.
Well, I just want to say, try it. Just look around you. I mean, we are dealing already every day with problems related to climate change and heat. Like in the last 2 weeks, we had to shut down theaters in my own department because of the heat and the ventilation system was not working. We are dealing with scarcity of pharmaceutical, of drapes and single-use items and everything, based mostly daily. So just start talking with your colleagues and just not assume that's normal. And then just we have to deal with it and just to, make the best of it. We can change that and we can try to make it different. So I think that's the most important thing to do. Just talk with your colleagues and just have a discussion and ask if we can find a different way, and then start from, small things, and things can happen. We are already seeing this every day. So what else do we need? Nothing, I would say. Yeah.
Absolutely. I don't want to misattribute the quote, but I have read before that the two most powerful words in the world are "me too," and I think that exemplifies what you just said. That you speak to someone and they might be like, "Oh yeah, me too," or I've thought about this." Same thing. So on that note, we are at the end of today's webinar. I regret that we didn't have a little more time to talk to you all and draw your insights together, but I am really grateful that you all joined us, Johnny as well, who we lost there. But your insights were super, super valuable and very appreciated. So thank you for all being with us today. Appreciate it. Now, I also want to thank our audience as well for being super engaged and being present with us. It's been a pleasure to have you here today. The key message from today's session, which I want to hammer home before I wrap up here, is that decarbonizing clinical settings depends on collaboration across the entire healthcare ecosystem, whether it's frontline nurses and clinicians to educators, engineers, researchers, and health system leaders. There is no single pathway to sustainable surgical care, and no individual, profession, department, or organization can achieve this transition alone. I also want to highlight a comment that Marie left in the chat, I believe, that sometimes interventions from elsewhere in the world where they're lower resourced in the first place can really surprise those of us that are used to having access to so much and overusing so much. So it's a great reminder to keep our eyes peeled for innovation in ways we didn't expect. And real progress happens when we learn from one another and we adapt our approaches to our own context and working together to embed sustainability into everyday clinical practice, which is, of course, our ultimate goal as an organization to help you to do that. I hope this webinar has provided you with some practical ideas. And on that note, I want to quickly mention a campaign that we're working on. Some of the speakers here today mentioned extreme heat and what it's been like in their direct practice, indeed, in the case of Johnny and Federica and what they've been dealing with. And this is the topic of a campaign we're doing right now called Handle the Heat. It focuses on strengthening climate resilience across health systems in response to the rising frequency of periods of extreme heat that we're seeing in Europe year after year. The goal in general is to help protect patient care by supporting health professionals so that you can continue to work safely and effectively to do your jobs. We are mobilizing health professionals that are willing to add their name and representative bodies on a letter to the European Commission calling for a comprehensive climate and health strategy, which in our opinion as an organization is way overdue and is much needed to give a comprehensive EU-wide response. We know some of the audience here today will be based in the UK and you may not feel this applies to you as much, but your voices really still matter and represent people on the very front line. So please, if you feel called to, find the link in the chat and add your name. And you can also explore what other organizations have endorsed it, which include Federica's Italian Center for Sustainable Healthcare, the European Federation of Nurses Association, the World Organization of Family Doctors Europe, and the Dutch Green Health Alliance, and many more. You'll also find a chat link to explore the full campaign if you're interested in getting involved. And lastly, as you leave, we'd be grateful if you could take a quick moment to complete our short post-event survey that will pop up on your screen. This feedback will really help us to improve future webinars and develop better resources for you to support the work that you're doing in decarbonization and in other topics in healthcare sustainability. A recording of this webinar will be made soon available on our YouTube, hopefully later this week. Keep an eye on our newsletter and our social media for updates, as well on the resource that we mentioned a few times that will come out later this year. And on that note, I will give you on to the rest of your day. Thank you very, very much for joining us. We really appreciate your presence and your engagement, and we look forward to continuing the conversation on low carbon healthcare in our future events. Have a wonderful rest of your day. Goodbye.